continuing our discussion of clinical indications for ultrasound. We said in the last section the clinical indications. So when you want to use ultrasound is when you have soft tissue shortening, when you need to do pain control. Dermal ulcers, ultrasound is used a lot for wound healing. Surgical skin incisions, tendon and ligament injuries. Remember, those collagen tissues take up more of the ultrasound energy. Fractures, carpal tunnel syndrome, and phonophoresis. Carpal tunnel syndrome, that transverse carpal ligament, the ligament is going to take up a lot of the ultrasound energy, and so we can improve the tissue extensibility there. And phonophoresis is where we use the ultrasound to drive in a medication, usually an anti-inflammatory medication, transdermally. So it's usually a topical drug, and we're using the ultrasound to physically push it into the skin. So the current recommendations for phonophoresis in terms of settings are 3 megahertz, so that's our more shallow, higher frequency application. Pulsed ultrasound at a 20% duty cycle. Pretty low intensities, 0.5 to 0.75 watts per centimeter squared for 5 to 10 minutes. So some of the studies show both heat and mechanical effects of ultrasound to be helpful, but you need the media, which is usually the topical drug comes in a cream. You need that to be able to penetrate the skin. I've really only ever been in one clinic where phonophoresis was done on a regular basis, and it's not unlike just performing an ultrasound. The main difference is the medium that you use. So when you are doing a direct application of ultrasound, you need a coupling gel. So you can there are some different ultrasound gels you can use, and we will try them in the lab. You want to choose the size of sound head that is appropriate for the area. So if you're doing a larger area, you want a larger sound head. If you're doing a smaller area, you want a smaller sound head. So the area, you have to look at the area that you want to treat, and you want the area to be about 2 times the effective radiating area. So that's pretty small. If you have a 10 centimeter head, your ERA is probably going to be about 8 centimeters. So you're going to do, it's pretty small. It's a couple inches. So it's a pretty concentrated treatment. The speed at which you want to move the ultrasound head is 4 centimeters per second. So 4 centimeters per second, that's pretty slow. So we can time ourselves in the lab and we can see, are we moving the ultrasound head too fast? So in that video that was posted in the module, think about 4 centimeters per second. Watch that video and see if you think he's moving the ultrasound head too fast. So this is in the book, and I really like it. It's a clinical decision-making grid, or flow chart, basically, for deciding what treatments you're going to use in ultrasound. So, and it has two indications, soft tissue shortening and delayed tissue healing or prolonged inflammation. So with the soft tissue shortening, you're going to use thermal ultrasound. You're going to use, and thermal is always 100% duty cycle. If the depth of the problem is 1 to 2 centimeters, you're going to use a 3 megahertz frequency. And the intensity is going to start at 0.5 watts per centimeter squared, but of course we know with a thermal treatment, we're going to use the patient's feedback as to whether or not they feel warmth as how much we're going to turn it up for the least effective dosage. And we're doing it 5 to 10 minutes and an area the size of 2 times the effective radiating area. So if you have a bigger area that you have to use, you're going to have to take more time to do that. So sometimes I will document, say that I'm doing, say that I'm working with someone who has a rotator cuff injury and maybe they have some impingement and some bicipital tendonitis as well. So I want to work on the long head of the biceps tendon on the anterior shoulder and the rotator cuff on the posterior shoulder. I will do 2 fields of 8 to 10 minutes each. And I will document it that way. I'll say, ultrasound, here are my parameters, 2 fields, and I'll state where the 2 fields are and how long I did in each field. If we're, say, for the delayed tissue healing or prolonged inflammation, we're going to use a non-thermal ultrasound effect, or we're trying for that. We're going to use that 20% duty cycle. We are looking at the depth of our problem again to decide the frequency, and we're going to start between 0.5 to 1 watts per centimeter squared. And that's pretty much where we're going to stay, because usually the lower watts per centimeter squared are going to go with the higher intensity, because we're not getting a thermal effect, so the patient's feedback isn't going to tell us to turn up the intensity. So this is applying ultrasound underwater. So one of the advantages to using water as your coupling agent is if you're doing something that's highly contoured like a foot or an ankle, and you might not get good contact using gel as your coupling agent. So you're going to use water. And we'll try this in the lab and you'll see. So you can use, there's a little style for ultrasound application. You can use like a loop-de-loop, as long as you're going no faster than 4 centimeters per second, or you could use a zigzag. So you can experiment and see which feels most comfortable to you. One of the things with learning ultrasound is learning the correct speed to elicit the correct feedback from the patient, and then to develop your coordination, and you're turning on the machine and you're moving the ultrasound head at the same time, and just developing that coordination of doing all those things at once. So this is treatment of ultrasound for a venous stasis ulcer. This is using an ultrasound coupling sheet for direct treatment on a wound. And this is a study that is stated in the book where ultrasound was used for fracture healing. So the left side used ultrasound and the right side did not use ultrasound, and you can see that there is more bone healing on the left side where they used ultrasound. So you can look at the details of the study in the book. And this was an animal study, so animal studies aren't always clinically relevant because, of course, animals are going to be different, but a lot of times they are a starting place, and then the human studies can go on from there. So contraindications and precautions, absolute contraindications for ultrasound: malignancy, pregnancy, central nervous system tissue, joint cement. So if somebody has had a total joint replacement, do not ultrasound their total joint replacement, because you can loosen their prosthesis, because it actually, the ultrasound energy can break up the joint cement. Plastic parts. So if somebody has an implant that has plastic, you don't want to use ultrasound there. If somebody has a pacemaker, thrombophlebitis, because we don't want to jostle those clots loose. And eyes and reproductive organ. I cannot imagine a scenario where I would want to use ultrasound on someone's eyes, but there you go. Precautions, meaning be careful, but you might use it, you might not, are in times of acute inflammation. You don't want to use it on epiphyseal plates on not fully grown human beings, so children. You might not use it on fractures, and you probably won't use it on breast implants. So the adverse effects potentially of ultrasound are burns. If you don't move the sound head, you could burn somebody, because that peak area of intensity, that spatial peak, is going to be in the same place. So you always want to move the sound head at 4 centimeters per second. Standing waves, and we'll talk about those in a second, and the potential for cross-contamination and infection. So I just kind of make it a general rule. I sterilize the ultrasound head before and after I use it. So I don't assume that the person who used it before me sterilized the head. They probably did, but I don't assume that. I sterilize it before and after I use it on the patient. So a standing wave, if you were to hold the ultrasound head in one place, you could get into a situation where waves going in and reflecting back start to sync up, The reflecting wave superimposes on the incident wave and it causes higher peaks of intensity. So you potentially have very high intensity. You can avoid a standing wave by keeping the sound head moving throughout the treatment. So you can actually burn somebody's periosteum because bones reflect a lot of ultrasound. If you hold the transducer head in place and you get that standing wave reflecting back and multiplying, you get potentially a very high intensity that can burn tissues. So keep that sound head moving at 4 centimeters per second. You always want to document, of course, the area treated. If you do more than one field, document that. The frequency, intensity, duty cycle, treatment duration. If you don't document that you did it underwater, it will be assumed that you didn't. But if you do it underwater, document that. And of course, you want to always, with everything we do, we want to document the patient's response to the intervention. The thing we don't want to say is patient tolerated the treatment well. You could say patient tolerated ultrasound with no complaints of increased pain. That's okay. That's more specific, not vague like tolerated treatment well.